Hi, everybody. Good morning. My name is John DiMuro. I'm the Chief Medical Officer for the state of Nevada. I'm happy to be here today with Project Echo to deliver this presentation. This is a long presentation. It's about 75 slides, but I am from New York and I can speak very quickly. The first half of this presentation will be very much directed towards the bill, Assembly Bill 474, signed and sponsored by the governor. The second half is going to be more towards diagnosing pain syndromes and just informing and educating everyone on how we can come to evidence-based diagnoses in pain. So, Jordan, how do we work with questions? Do people come in or do we do anything?
So
okay.
You put them in the chat.
Okay.
And we'll address them.
All right, great. Now, this is the first time I've ever given a presentation and not been able to walk around a podium, so I apologize for any weirdness that may take place as I look at a computer screen. So thanks for coming, everyone, and we'll get started. So that's me. Okay, so we're going to talk today about Assembly Bill 474, which is the Controlled Substance Abuse Prevention Act. And it was passed in 2017. This was passed unanimously. There was no opposition. We had engaged stakeholders for 6 months prior to moving into the legislative session. So we're very, very happy. We were out in front of this bill from the very beginning. So what was the task? When I took this position, I'm dual board certified in anesthesiology and pain medicine. So I've been writing prescriptions and practicing pain medicine for 13 years. So I was tasked with use the state data, determine a problem, and then create a rational bill. And we wanted to make sure that the state agencies were able to communicate amongst each other, especially when we look at the data. I think we all see these graphs in the newspapers about all of the deaths from opioids, but a lot of this is polysubstance abuse, and I don't think the data is as broken down as physicians would want to see this. What are the barriers? Obviously, this is the barriers: legislators, lobbyists, the public, prescriber groups, and time. I'll speak to you at the end about some of the feedback that I've received from some of the physicians. So what did I need to do? I needed to write this bill to appease all groups. As you can imagine, in politics, it can be very difficult. The problem is the abuse, misuse, and diversion, right? We do this every day on our prescriptions. We have the illicit drugs and illicit drugs, and we really had to concentrate. This isn't working, Jordan.
Sorry, I was trying to for you.
Okay. The illicit problem and the illicits. Obviously, the illicit drugs are going to be very difficult to get between dealing with the dark web and how people can order fentanyl powder and get it sent to their door. The big issue was the supply of legal drugs, the overprescribing. Surgeons, whether it's surgeons, primary care, pain doctors like myself, and the logistical constraints in such a big state that we have. Also, dentists needed to own their role in this as well. And many dentists looked at me like, we're not the problem. Well, when I look at the PDMP, everyone on this conference would be very shocked to see what's happening in the dental world. And then, of course, we have a lack of access to appropriate providers. Next slide, please. According to data, we're finding that there was no checking of the PDMP prior to prescribing, yet this was the only mandate in the code. Even though you're supposed to be registered with the PDMP, not everyone was. The DO board was actually very good. They would have punitive measures if you were not. The MD board, there was a big issue because if the MD board looked into this, it would be a, quote, investigation. So I can understand the MD boards not actively discussing the issues with their licensees because we don't want to open investigations just because you did not register for the PDMP. So I saw the obstacles that the MD board was up against. And then the Board of Pharmacy, I just want to let everyone know, the Board of Pharmacy sees everywhere you click when you're on that PDMP. So you can say, oh, I checked Sally Smith's PDMP. Well, trust me, if you didn't click in Sally Smith's PDMP log, they have it that you did not log in. So they know everything. Next slide, please. High quantity of pills prescribed. Obviously, it's a convenience for prescribers, especially out in the rurals. I get it. You don't want patients traveling an hour, 2 hours, 3 hours just to get a prescription. The dental prescriptions, a lot of people who are prescribing don't understand about alternative treatments that are available. We're going to discuss that at the end. Poor access to these treatments, whether or not they're yoga, Pilates, massage, or interventional pain treatments like I've always done. And of course, there's insurance limitations. Many of you out in the rules are seeing Medicaid patients, and Medicaid may not cover certain types of treatments. I assure you I've been working with Medicaid weekly on this issue. Next, please. High number of polypharmacy prescriptions. I get it. We sometimes get guilted or forced into writing for combinations of medications that we don't need. I want everyone to know I understand this, and I've been in the same issue myself. You have patients who are on Ambien for a long time. They want a little bit of Xanax. Meanwhile, they have a legitimate pain problem. We worry about referrals, especially subspecialists, and you worry about the fear of reprisal from the patient. I had to inform the government people that I deal with that, hey, when someone goes on the internet and they rip you apart on a Yelp interview or on Yahoo, that's a real problem. So I'm trying to make people understand what we go through as physicians. Also, when you take over medications from another provider, patients don't want to go off their medications. So I want everyone to understand, I know this, and I took this into account when we wrote this bill. Next slide, please. Lack of evidence-based diagnosis. This is a big one to me as a diagnostician, which is the number one problem that we see in the Medicaid rolls is dorsopathy. Well, you can't just continue to write dorsopathy on a medical record without investigating what the problem is. You'll look very silly if the patient has a meningioma or a fracture and you've been giving opioids without an evidence-based diagnosis. Also, patients will refuse, as we well know, to adhere to our recommendations and referrals. And once again, those logistical constraints. Next slide, please. Lack of provider follow-up. Again, these are things that we can't control for the most part, but inconsistent providers. Some places we have locums doctors coming in and helping out, or there's a new nurse practitioner out in the rurals. So also, in not heeding warnings from the Board of Pharmacy, I have to say the Board of Pharmacy has been very supportive to me since I've been in this role for 18 months, and they're very good at getting letters out. My advice is if the Board of Pharmacy calls you or if they send you a letter, please read it. The Board of Pharmacy is really an outstanding organization here in Nevada. Next slide, please. Lack of appropriate screening. Many of us don't use valid risk screening tools. We may not have the time. We're not doing required or regimented body fluid checks. I will tell you, very important for everyone to know, it is the only issue that I don't like about the bill is that I was asked to remove that section from the bill. So I just want everyone on this call to know that there is no law that requires a urinalysis or blood work. That is totally up to the practitioner. Also, the poor understanding of long-term effects of chronic use, whether it's addiction or hormonal issues like decreased testosterone levels. Next slide, please. Who's responsible? We're all responsible. We can blame everyone, and I think everyone gets that. Next slide, please. Governor Sandoval's bill, this passed unanimously. The governor gets to sponsor 5 bills. This was one of them. The governor hosted a summit, an opioid summit, August 30th, September 1 of last year. It was very well attended, and we took the recommendations from that summit when we moved forward. Next slide, please. Okay, what are the major points of this bill? Number one, it does not handcuff the physician, or I should say prescriber. I want everyone to know you can write for whatever drug you want, whatever quantity you want. You have to own it. So if anyone tells you that this is a physician-restrictive bill, they are wrong. You can write for whatever drug you want, whatever quantity. Next point, next slide. You must register with the PDMP. One of the ideas we had is that when you register for your medical license, you must be registered with the PDMP at that time. So that way we ensure 100% compliance. Next slide, please. Must have normal follow-ups. It's inappropriate to have patients on controlled substances and not see them every 90 days. Okay, evidence-based diagnosis workup. We need to make sure that we know what the patient has. Again, this diagnosis of dorsopathy, it's not fair to the patient, and it's not fair to you to continue to write for controlled substances at a patient's request without even knowing what you're treating. Next slide. Changes in board oversight. As I had spoken about before, with regard to the MD board especially, the MD board is now going to be able to discuss things with their licensees without worrying about a formal investigation. Next slide. Prescription changes. There's specific items that will need to be on a prescription. For example, one of the reasons people will blame the Board of Pharmacy is that they don't update their PDMP quickly enough. What people need to understand is doctors that work out of the OR, like me, and surgeons may have to use hospital prescription blank, and we don't have a pre-printed DEA on that pad. So what happens is the Board of Pharmacy, if you don't write your name out and print it out and write your DEA number on it, the Board of Pharmacy is unable to update their system. So everyone needs to understand why the PDMP may have been faulty. Next slide. What's the crux of the bill? This is called Prescribe 365. This is something I came up with because, in my opinion, no patient should have more than 365 days of medicine in any 365-day period. You wouldn't give a patient 366 days of chemotherapy in 1 year. You shouldn't give a patient 366 days of thyroid hormone or antihypertensives. So it's the same thing. When I looked at the data, when I took this position, the patients who were abusing, misusing, and diverting medications were patients that were given 450 or 500 days of medicine. How does that happen? The patient gets a 30-day prescription on January 1st, which should run for the entire month. And then what happens? The patient breaks their ankle on January 15th. They get an additional 2 weeks of medication. Well, that patient has now had 44 days of medicine over a 30-day period. So that should last them until February 14th. That shouldn't be that the patient gets 44 days of meds in 30 days. Like I said when I started this conversation today, in no way, shape, or form does this bill restrict what drug you can write, what quantity of pills you can write, or the dose. I want to be very clear on that. Next slide. The changes to the Nevada laws for the controlled substance for the treatment of pain. That's what we're talking about here. This is a very busy slide. We're happy to disseminate it. Basically, it breaks down the bill. These are some of the points. We cover that the controlled substance should be working as intended for the patient's symptoms, that the provider has the ability to stop prescribing or recommend certain behavioral health types of treatments. We have, by the way, for everyone watching, we have a white paper on this that was created by the Board of Nursing with a one-sheet breakdown of the bill. So I hate busy slides, but I just wanted to kind of throw this in. The initial prescription is the only time we put some mandates in there, and it's because when you write that initial prescription, and this is defined in statute, if you're writing an initial prescription, you don't know that patient, right? You're writing it for the first time. We have to make sure you check that PDMP. You need to make sure that you have at least a differential diagnosis. And we want to keep it third line from the bottom, less than a 14-day supply. You don't want to find out 7 days after you write that prescription that, oh my gosh, why did I write for 90 days or 30 days at this dose when new information comes in, right? Also, that second line from the bottom, it shouldn't be for more than 90 morphine milliequivalents a day. As a pain doctor, there's no way I would ever write for more than 90 morphine milliequivalents a day. That's akin to about 60 to 70 milligrams of oxycodone or about 90 milligrams of hydrocodone a day. For an initial prescription, that's like writing for a 10 milligram pill every 2 to 4 hours. If you don't know the patient, you don't know what's wrong. I think we can all agree that would be inappropriate. And we also want that informed consent. Patient needs to know what's going on and why you're recommending opioids. Next slide, please. Obviously, that risk assessment, you need to look at the patient's medical history and records. All we want to see in the medical record is that you've made an attempt to get those medical records. We all know how difficult it is to get them, especially patients treated over state lines. And we want to make sure you have an appropriate physical examination. You can't just have a one-line handwritten note in the chart and start a patient on oxycodone. This problem we all have to kick in. Okay, I've had surgeons who've asked me about this stuff. I've had oncologists who say, well, you don't understand. No, I do understand. And if anybody sits there who's out there today and reads this bill, I think you'll see how rational it is. The informed consent, we want to make sure we protect the physician. To me, this bill is going to be like the electronic medical record. We all hated it when we started with it, but now when we look back, it's nice to know at the click of a button, we can look back 2 years ago and see what our note was and see it was very clear and look at the ICD-10 diagnoses. So we want patients to know about the potential risks and benefits, the proper use and storage. What about pregnant moms? Do you really want to get sued because a pregnant mom says you never told them what could happen, or that neonatal abstinence syndrome can develop? Trust me, I've seen it. I'll also tell you that there's some data coming out of the southern part of our state showing that the incidence of babies being born with polysubstance addiction is greater than 70%. I can't tell you where it's coming from, and I can't tell you, but this data is going to be published in the next 6 months. Also, unemancipated minors. Next slide, please. If you decide that you're going to continue the patient on meds for greater than 30 days, then we really have to engage that patient and let them know why. And that's what this slide discusses. Also, another point I want everyone to know is there are no specifics on what to do with a patient who's on marijuana. That's up to you as a provider. Okay, this is a recreational drug now. It's like alcohol. You have to decide. So I don't want any. I've heard it several times. Well, what do you want us to do if a patient's on marijuana? It's up to you. You're a physician. You have to decide what's best for your patient. Again, that's the spirit that this bill is written. That you practice medicine, and we just want to make sure that the patient is safe and that you decrease your liability. Prescribing after 90 days, now you really need to know what's wrong with the patient. So if you're out in the rurals and you give that patient 4 to 6 weeks of physical therapy, maybe it takes them 90 days, 3 months to complete that course. If you're going to continue with opioids and or benzodiazepines and or sleepers, well, now you owe that patient and yourself to find the appropriate risk and what's wrong with that patient. And that's what this part of the bill is about. And if you look on the bottom, you need to develop a revised treatment plan. So at that point, if you said this is just a case of low back pain, you have the patient on physical therapy, anti-inflammatories, and a small dose of oxycodone, that's great. But if the patient hasn't changed in 90 days, we should be looking at a diagnosis, whether it's flexion and extension x-rays, if it's back pain, MRIs, or referral out to a specialist. But after 90 days, it's inappropriate to continue patients on these meds. Again, when this bill was written, I looked at the data on imaging studies, and I looked at how long patients were continued on these controlled substances without an evidence-based diagnosis. Next slide, please. Prescribing after a year. After a year, you should be looking and checking that PDMP every 90 days. You'll see if you're exceeding that 365 days. Again, the prescribed 365, it was just kind of a little reminder in everyone's head to not prescribe more than there are days in a year. What the plan on this is to flag the Board of Pharmacy at 400 days. So when more than 365 days of one substance, so you can have a patient on OxyContin 365 days, and oxycodone 365 days, and Ambien 365 days, and Dilaudid 365 days, whatever you as a physician feel is appropriate. However, there's no reason to give 500 days of OxyContin. And I'm not saying that you as the prescriber did that. There could be several doctors prescribing. By checking the PDMP, you'll be able to add up those days very quickly. If the pharmacy sees that you're over 400 days, then they'll let you know with a letter. And they'll say, hey, by the way, did you know that Sally Smith has 401 days of OxyContin so far, and it's only September? Obviously, we all want to keep the dose to the least amount where we can gain the desired effect. So these are common issues that the guidelines that the CDC wrote. Another thing I want to point out is the CDC guidelines were just that, guidelines. I'm not a guideline kind of guy. We're physicians. Guidelines are always for someone else. We needed to do mandates that protect everyone, including the physician. We always want to protect the patient, but we want to make sure that I wanted to make sure as a practicing physician that all the physicians are protected as well. Next slide, please.
Sure, we have a question.
Sure.
The logistics behind obtaining written informed consent to the extent listed in AB474 may be rather prohibitive and difficult to implement. So will there be a standardized form made available for use?
Excellent question. So I was just discussing prior to the start that Dr. Stephanie Woodard, who co-wrote the bill with me, who's a behavioral health specialist, and I are creating individual forms for compliance. And we're going to place that on the Department of Health and Human Services website so that they can be downloaded and edited by each of you into however you want to do it in your practice. In other words, you're not going to refill on Tuesdays and Thursdays. You can edit and modify the document. So everything in order to make this bill compliant will be easy for you to do with the forms that Dr. Woodard and I are in the midst of creating. They'll all be available on the internet.
Awesome, thank you.
So what I wanted to do, so that's the first half of the presentation. I wanted to make sure I covered that. I know many of you are very busy. What I wanted to show everyone, though, is there actually are ways to work patients up in the pain world. So I wanted to explain this and go through and give you kind of a visual as to some of the work that we do in interventional pain medicine to come up with evidence-based pain diagnoses. Next slide, please. So what is the job of the pain doctor? To obtain an appropriate pain diagnosis and then tell patients what their options are. Obviously, if there's a tumor, I want to make sure their option is getting them to an appropriate surgeon. Next slide, please. What's the difference between a medical diagnosis and pain diagnosis? Many of our colleagues don't understand the difference. So a medical diagnosis is that ICD-10 that you put in there, whether it's a dorsopathy. So you put low back pain. Next slide. Pain diagnosis is very specific. Is that pain coming from the disc and or a nerve root? So it's a much more specific diagnosis. What I'm here to tell you today is that we have the means of finding these things out. I know that there are many surgeons that we all deal with in this state who just want to cut. I get it, and I don't support it. Anyone who has spinal surgery, especially, and I'm just going after spine surgery right now, they should have an evidence-based diagnosis. We shouldn't be treating x-rays. We should be treating evidence-based diagnoses. So what do we typically do? So all of the providers that we have here, and I apologize if you're not in here, typically we have this group of 7 types of providers. Next slide, please. What's the difference? Massage therapists, they do their diagnosing feedback and assessment of the soma. Next slide, please. Acupuncturists have their own way of doing their things. And if you look on the very bottom there, meridians. Next slide, please. Athletic trainers who are fairly good at diagnosing, they'll look at these movement screens and anatomical assessments, and they'll get a little bit more into detail. They can tell hip flexors and things like that are deficient. Physical therapists, excellent diagnosticians. They'll usually refer out when they find specific musculoskeletal abnormalities. They can be a little bit more specific with their diagnoses, such as an iliopsoas syndrome. Next slide, please. Chiropractors are pretty good as well. They can obviously take x-rays, which helps them much more. They can also try to treat by doing their HVLA, high velocity, low amplitude thrusts and manipulations. Next slide, please. General physicians, obviously you have the gamut of diagnostic tests and blood work that you can use. And then typically that generalist physician, if they can't treat it, they'll move the patient on to the appropriate diagnostic or treating physician. Next slide, please. And then you have basically the interventional pain physician like myself, who basically takes all that information and then really tries to hone in on the diagnosis. Next slide, please. So how do we do this? Next slide, please. So we debrief with the family. We render opinions on the current diagnosis. We talk about the condition. Those A, B, C, D, and E, this is what I'm looking at in every patient. What is that type of insurance? Medicaid doesn't cover everything. Blue Cross may not cover everything. What's the risk and reward of treatment, whether it's surgical or non-surgical? Obviously, finance. You see all these patients who are spending thousands of dollars on stem cells and PRP, and there are a lot of doctors out there who frankly don't know what they're doing, and they're doing this for cash, and it's wrong. They're a cure versus Band-Aid. I always laugh when people say, well, an epidural steroid injection is a Band-Aid. Well, ask people who get epidural steroid injections regularly and do well and don't have to go in for surgery. Ask them if a Band-Aid is appropriate. Also, pertinent medical history. I just find that this is lacking because of the time constraints that face us all. Next slide, please. What are the treatment options? This is what I tell everybody. We can do nothing. We can look at medications. Next slide, please. Physical rehabilitation modalities. Here are all the things that I look at when I refer out. Next slide, please. Further diagnostic testing. There are diagnostic studies out there that many of you may not know about. My favorite is the MRI neurography, where I look for peripheral nerve entrapment type syndromes. But don't forget about those flexion extension x-rays. Sometimes I need a thin slice CT scan to see if there are issues in the high neck, especially after personal injury or accidents where patients have headaches. And CT arthrograms are still the treatment of choice for hip and shoulders where they don't have a high enough Tesla magnet to do an appropriate MRI. We refer out appropriately. I test for hormones, and I look at all these different issues. When I'm being a pain doctor, I really am dialed into finding that evidence-based diagnosis. Surgical referral, obviously that's the big one for me. I always say I don't refer to a surgeon unless I know this patient is surgical. Diagnostic work-up to prove the diagnosis. This is where I'm really getting that evidence-based diagnosis. So next slide, please. So how do I arrive at a definitive diagnosis? Well, it depends what I'm trying to prove. Next slide. So these are the 9 issues that I look at with every patient. So I always laugh when people review an MRI and the MRI looks bad and they say, oh, well, it's your disc that's causing the pain. That's wrong. You can't say that. I've testified many times in court with attorneys who will say to me, well, you can see that that disc is herniated. Isn't that where the pain is coming from, and doesn't this patient need surgery? No. You can't tell that it's painful just because something doesn't look right. Okay, if we MRI everybody on this call right now, 70% of us will have some type of abnormality. All right, so disc, joint, nerve, muscle, bone, tendon, ligament, peripheral nerve, and organ. So all of you may be saying right now, you can't tell the difference between what's going on with those 9 different areas. Well, we actually can, and fairly well. Next slide, please. So what if there's a problem with the disc or concern over the disc? How do we figure out if that's a source of pain or discomfort? Do I just diagnose it off an MRI? Do I movement screen that patient? No, we can actually do a scientific diagnosis here. Next slide, please. So there's something called provocation discography or discogram. Next slide, please. This is how we stimulate the disc in order to see if it's painful. We actually inject it with contrast dye under live fluoroscopy, and then we send the patient in for immediate CAT scan after. Next slide, please. So here's a picture of a discogram that I performed. And what you can see on the left slide is I'm putting needles directly into the nucleus of the disc, and then I inject contrast. And if you look on the right side, you can see what the contrast looks like. And we actually call that a puffy cloud or a cloud-like appearance to the disc. Well, what does a pathological disc look like? Pathological disc looks like this. If you see the slide on the right, there's that nice hamburger or puffy cloud in there. Then on the right, you can see the leak into the epidural space. So that's a tear. It doesn't mean it's a painful tear. That's information that I'm eliciting on the operating room table when I perform that procedure. But I want people to know that we can figure out if there is a problem with the disc in a pretty reliable way. Next slide, please. So if that comes up where a patient has a torn disc that's symptomatic, we can send it for surgery, or I can do something called a transdiscal biaculoplasty. This is where I actually burn the pain fibers in the disc. Very, very well received, easy to do procedure that patients can do very well with. Slide. Joint. What about if a patient has joint? Oh, well, you look at a patient's MRI. Oh, well, it's your joints that hurt. You need surgery. They've got to really shave that joint down. Well, not necessarily. How can we prove that the joint is a source of pain? Next slide, please. So here's a picture of the lumbar spine on the left side, just a PA fluoroscopy image. And if we look on the right side, what I've done is I've taken needles and I've put them into what we call the facet joints. You can look at the lowest of the 3 needles and see I've injected contrast and I've created a facet arthrogram. I can assess that morphology, and I'm going to inject local anesthetic, high potency local anesthetic, and cortisone. So this is a facet joint injection in order to diagnose facet-mediated pain. Next slide, please. So what if we find out that the joint is painful? Well, there are a couple things that we can do. Sometimes if that joint is really painful and it's a very large joint that's impinging within the neuraxis, we might have to send them for surgery. They might get that thing that you see as a medial facetectomy, or where they have to shave down the part of the joint that's into the neuraxis. The radiofrequency ablation, I think we all know that as an RF. We can actually cauterize that joint, or basically burn the medial branch, which will actually decrease the pain and actually shrink the joint. It's a pretty neat procedure. Sometimes the patient just needs therapy or a chiropractor to manipulate that joint. Sometimes they just need some exercise, and then we can send them to a trainer. What about if we think there's a certain nerve abnormality, whether it's a nerve in the neck, spinal nerve that goes down the arm, or if it goes down the leg, like the sciatic, right? What do we do about that? Well, here's a picture where I'm performing what's called a selective nerve root block. It's very important for everyone to understand this is not an epidural. This is a diagnostic procedure. Epidural steroid injections are therapeutic. Selective nerve root blocks are diagnostic. You can see in this procedure what I've done is I've placed the needle to place contrast dye and local anesthetic and steroid over one specific nerve. You can see very clearly on that right-sided image, all I've done is covered one nerve. An epidural, as we probably all realize, covers many nerves. This is why women can have babies and feel no pain, because that local anesthetic goes into the neuraxis and it numbs all the nerves in that lumbar plexus, right? The sacral plexus. So here it's one specific nerve. Next slide, please. So what are the dangers? You can see on the right side, that's the vertebral artery that goes right to the brain. You can actually, if you look real closely, you can see the kinks to it. So this is why it's very important to make sure that people that do your diagnostics are very cognizant of these things and understand what goes on. So that does happen. So what happens if a patient has a positive selective nerve root block? This may be a prelude to surgery. This may be the diagnostic information that a surgeon needs to know which level to operate on. We've all seen where these patients undergo 4-level spinal fusions, and they may have just needed one. They might just need an epidural, or can you go back one slide there? Or they might just need physical rehabilitation modalities. Next slide. So what if it's muscle? People say, oh, you're just having muscle pain. Well, if you can differentiate muscle pain from something in the spine, you're better than me, because it's very hard to do without appropriate diagnostics. Guess what? We can actually inject muscle using fluoroscopic guides. So here's a picture, next slide, where I'm actually selectively injecting the gluteus medius muscle. So this can be done. In the right hands, we can actually diagnose. So what you see is from one needle placement, I've been able to cover that gluteus medius muscle and selectively inject the gluteus medius, as opposed to trigger point injections where who knows where the local anesthetic is going, right? We're just really, when you do a trigger point injection, I've done millions of them, I'm sure you guys have done them as well, you're just putting local anesthetic in a field block along an area you think hurts. And that's fine, it may help the patient. But realize that we can actually do this selectively. Next slide, please. What if the patient is positive for it, gets great relief from that muscular injection that we do selectively? Well, they might need physical rehabilitation modalities. Sometimes I find tears in there, and they may need prolotherapy. So these prolotherapies are proliferative type therapies. Sometimes you can do them with sugar type therapies, dextrose. Sometimes we do PRP, stem cells, things like that. Sometimes if the muscle is very spastic, we put Botox in there. And sometimes we can give the patient oral or injectable medication. Next slide, please. What if it's bone? Patients who have pain after a kyphoplasty. We don't have to keep these patients on chronic opioids or controlled substances. We can actually obtain appropriate imaging studies, and we can ablate certain nerves. There's actually a rami communicans nerve that we can actually perform a radiofrequency ablation. Sometimes we do need alternative medications. Maybe they're bisphosphonates. Maybe we just need to brace that patient, see if it heals, and follow up with imaging studies. Next slide, please. What if it's a tendon? The big one is for lateral epicondylitis. Right, the extensor tendon. Well, we can actually inject that as well, and we can brace it, prolotherapy. These are very specific things that the pain doctor can do under fluoroscopic guidance. Next slide, please. What if it's a ligament? These are very hard to do. This is where ultrasound really comes in if we're going to look at a specific ligament problem. Again, I implore everybody that just because someone comes back with a pathological imaging study, it doesn't mean that that pathology is what's causing the pain. I can't emphasize that enough. What if it's a peripheral nerve? The big one that we'll probably all see is a lateral femoral cutaneous, a neuralgia paresthetica. Sometimes we'll see ilioinguinal nerve entrapment after hormeorrhaphy. Sometimes you'll have patients who have pain going down to the genital, especially with men going down to the testicle, and we want to go and do a peripheral nerve injection. We can do that as well, and we can use at the bottom on the right there in red, desensitization injections, using the right combination of drugs. Clonidine is a big one, alpha agonists. We can actually treat these peripheral nerve impingements. Cluneal nerve injection. This is a big one that's overlooked when it comes to back pain. The cluneal nerves sit right over that ilium. We can actually ablate them as well. Next slide, please. What if it's organ pain? So visceral pain syndromes are, number one, they don't respond to opioids reliably, and number two, they're commonly misdiagnosed and mistreated. So if patients come in and they have bad menstrual periods, and they have uterine pain, ovarian pain, most people, most doctors, most primary care people, especially if they don't have access to specialists, they'll increase doses of muscle relaxants, benzos, and opiates. This is not the right thing to do. And again, this is what gets into the problem with controlled substances and the opioid crisis, is I can't blame the physicians who are trying to treat the patient. But what I'm trying to do today is educate all of you out there that there are things that we can do. We can actually do sympathetic blocks. Sometimes these patients need surgery. If it's an organ such as a hysterectomy or an oophorectomy, sometimes they need a different combination of medications, not opioids. Sometimes it's a nutritional issue as well if you look at issues that occur with the colon or gallbladder, right? I'm sure we're all aware there. Next slide will show a picture of me doing a celiac plexus block. And the difference in this block, if you look on the left side, is you can see that I've placed the needles anterior to the vertebral body. So remember, the sympathetic plexus lays in that antero or anterolateral aspect of the vertebral body. The whole trick of this procedure is not to hit the aorta or the vena cava, but to wrap that needle around to the anterior part of the vertebrae. And you can see from the picture on the right how that contrast is spreading and that we're able to cover the appropriate sympathetic target. Next slide, please. What are the take-home points? Realize that sometimes things aren't as simple as they look. Oh, your uterus hurts, your ovary hurts. Well, we just have to jack you up on the meds and that's it. this is a big one that I live by every day, including in my new role in the government. You can't say it if you can't prove it. Don't tell someone it's your disc that hurts when you have no evidence of it. You can tell patients, you know what, that disc looks really bad. That may be what's causing your pain. That may be why I want to start you on meds, and that may be why I'm going to refer you to a surgeon or a physical therapist. But you can't factually state that just because something looks bad on an imaging study, that's the problem. You look awfully silly when you have a patient you've sent for x-rays and you tell them, oh, you know what, yeah, you've got degenerative disc disease, that's your problem. And then when they get the MRI, they have a meningioma or they have a tumor in their cord. You look very, very silly. Number 3, we can prove these diagnoses. And the other thing, some people are just broken. They've got a bad shoulder, a bad hip. Listen, they've got a bamboo spine, they have degenerative joint disease in their spine and degenerative disc disease and stenosis, and they're a high risk for surgery. I get it. And this is why when we wrote that controlled substance bill, we made it where you can write for what you want at whatever dose you want. But we want to try to protect you and the patient equally as we move forward. Also, depth of knowledge is not well appreciated. Please appreciate that our colleagues have a wealth of knowledge in their areas of specialty. Yes, there are exceptions, and we don't agree that every doctor in every field is the best. There are good surgeons, there are bad surgeons, there are good primary care providers, there are bad primary care providers. And please realize, get opinions, get second opinions and third opinions, but just appreciate that some people do have a significant depth of knowledge that can help your patients. Thank you. That's a lot of work that we've covered in 40 minutes, and I'm happy to answer any questions if anyone has.
Go ahead, Sue.
When you say a controlled substance patient should be seen every 90 days, are you referring to Schedule 3, Schedule 2, etc.?
So Schedule 2 through 4 is what we're looking at there. Yeah, if it's a substance.
So you're talking about benzos and that's a schedule. Benzos are Schedule 4, aren't they?
Yeah, and I'm trying to include Schedule 5 because then you have the cough syrups and things like that. And that needs to be a part of this as well. So again, I want everyone that this bill was created rationally, and not being a bureaucrat, I wanted to make it very physician friendly. The bottom line is, if you get sued, you're going to have to answer in court, not me. That I do not want the state enforcing punitive measures. I will tell you that I had a conversation with an 87-year-old physician yesterday who thinks that physicians should go to jail, and that physician may be on this call right now, who thinks physicians should go to jail if they don't follow the law. And I would tell you that I told him last night, I don't feel that the state should tell the physician what to do. So yes, Schedule 2 through 4, and I'd like to see it Schedule 5. If you're giving a cough suppressant for longer than 90 days, we should really know why.
Thank you.
This question on your screen there.
Yes. The validated risk screening tools, of which I'm aware, are not applicable to patients evaluating ER or what specific tool emergency medicine. Accrued fracture provided 3-day supply of opioids. This is a good point. I would love for you to contact us to let us know what you feel is an appropriate screening tool. For the emergency rooms, really what we're looking for, again, this is rational legislation. We are not looking to come down on the ER doctor. We just want you to make sure you check that PDMP and you're not getting scammed. You don't want to be the guy that's giving the opioids or the controlled substances when that patient's been to 4 ERs in the last week. So what we will have, like I had said earlier, Dr. Woodard and I will be publishing what we feel are the best risk screening tools, and we are absolutely open to everyone telling us what we should put on the website for appropriate validated screening tools. With patients who are inherited from another provider, who have been receiving narcotics for years, that have become habituated, do I start from zero and re-diagnose? No, definitely don't want you to do that. Again, this is why I brought it up before. We can't help inheriting other patients. But what we're going to do is we want you to inherit that patient, get an appropriate diagnosis, and get that patient help. If they're stable on 500 milligrams of oxycodone a day, fine. Write for 500 milligrams of oxycodone a day. But that patient still deserves an evidence-based diagnosis. You still deserve to be covered in case you get sued and we have that issue that we had here in Northern Nevada with that one doctor who was prescribing a significant amount of meds and did have evidence-based diagnoses from the way it looks, and that case is still pending. So I want you to be protected. So if you inherit 500 milligrams of oxycodone a day, great, write for it if you think it's appropriate, but make sure you have copies of the imaging studies, or you order the imaging studies. You provide the patient with tools about addiction and what can happen in the long term. You get a blood test for testosterone levels and be a doctor. That's what I want everyone to do. If you're going to write for those meds, you have to own it and be a physician and do all the things that you need to do to protect yourself and the patient.
Any other questions?
Hi, so this is Kenny. I'm a nurse practitioner working with Love Lock, so rural. And so my question is based on my Medicaid patients.
Sorry, could you state that again? We're having a hard time hearing you.
So I'm on Love Lock, rural Nevada. And my question,
Yeah. Could you type into the chat because we cannot understand you?
And since we have some dead time right here, I would implore you to tell other providers, physicians, medical students, residents, this bill does not handcuff prescribers. The first prescription is the only time there's a limit, and I would want a limit as a pain doctor. It's nice to be able to tell a patient, I'm sorry, I can't give you 90 days of meds. We're starting you on opioids. We're starting you on Xanax. I'm going to give you 2 weeks work till I can make an attempt to get your medical records. Wait for the blood work to come back. So I don't want you to not treat the patient, but I want the prescriber to have an out, an ability to say, hey, I'm going to give you enough until I can figure out what's wrong. And I also, if we're prescribing substances and not following up with these patients every 90 days, that's a problem. Please realize we've all contributed to this. We all have to kick it in a little bit. The bill was written to not handcuff providers, and it was created to be rational and to make the prescriber realize there are behavioral health. There are patients that need to go to behavioral health. There are patients that need to know that options are available. We need to educate them. Let me and Dr. Woodard make the forms for you. Have your medical assistant download them. Every patient, when the forms that we give you and we'll make available, you put it in the chart on every patient and you're covered. That was the goal of this.
I understand the intent behind it, and actually I agree with all the details in it. I'm an emergency physician, and I think part of the concerns that I have surround the logistics of the time course that's available in an emergency department setting to write for a limited prescription for an ankle fracture or a severe injury. If we're writing for a 3-day prescription, the letter of the law as it's written, the details for the written informed consent are pretty onerous, and I think it's going to create some compliance difficulties in the emergency department setting.
So why do you say 3 days? Is there somewhere in that bill that says you can only write for 3 days?
Oh, no. I'm not saying that we're being limited by the bill to 3 days. I'm saying that's a typical practice in the emergency department. Typically, we're only writing for 3 days of prescriptions for many of these patients.
Okay.
Bridge them till they get to an orthopedic appointment, or assuming that their pain will be better within a couple days. So we're not writing for 14 days or 90 days of prescriptions. We're writing for very limited, usually we're writing for 10 to 15, either hydrocodone or oxycodone to get them through the next few days. And the amount of detail that's required in that written informed consent is pretty difficult to do in an emergency department setting where you are really already time pressured to see a ton of patients, especially in trauma center related patients.
So number one, if you can, and I should have brought the bill in with me as well as the white paper. If there's a specific section that you feel is pertinent or that ER doctors will have a problem with, please send it to my attention. It definitely was not meant to be that way. Totally get it. Also, we might be able to make a quick, and I'd love your input on this, whomever you are. I'd love to be able to create an emergency room form that we can put on the website. So I would love your help in creating a one-page form that you feel would cover emergency room doctors. How about that?
That would be fantastic. I would love it if you could maybe type in your email address into the Zoom chat area. That would help us.
Okay, that would be fun. Okay, I'll have Jordan do that, but I appreciate your input. Thank you.
Thanks.
Question? Yes, hello. Can you hear me?
Yes.
Okay, I'm Dr. Robert Hayes in Nye County. I practice in Pahrump. I have 40 years experience in primary care, and we're in a severely physician underserved area. And following these guidelines, like when doctors leave town, when I'm gone out of town, to follow the guidelines and have to see the patient to refill their medicine is really a problem for us because of access to care. And I'm thinking about leaving Nye County, number one, which is really an underserved physician area, and Nevada completely, and moving to another state because of this opiate issue. I cannot follow these guidelines.
So, once again, they're not guidelines. I made sure not to write guidelines. These are mandates. I want to be clear. Number two is if you are, and again, I'm dual boarded anesthesia and pain. If you are writing for controlled substances and not laying your eyes on that patient every 90 days, we have to question whether we're doing that patient a favor. How do we know the patient's condition hasn't changed? How do you know if you haven't done a physical examination or see if they're having side effects? Assessing them for constipation, checking their renal function, seeing if they're having sleep apnea issues. I mean, this 90-day issue is pretty much the standard of care in the pain world. So I understand the logistical issues, but if we can't see these patients every 90 days, I have a hard time thinking that if you have a patient on controlled substances, why we wouldn't follow up with them every 3 months. Are you saying that, I mean, do you have a specific number of days that you feel is appropriate for patients to follow up? And should patients in the rural areas be treated differently from patients in the city?
But I tell you, access to care out here is a reality, and you can't run from it. And we can't get everybody in. I'm dealing with people dying every week. And I got to triage some of my patients. When my partners leave town and stuff, we can't always, it's difficult to do that unless we're here till 10 o'clock at night, and I'm not going to do it.
And I get it. I will tell you, I've been to Desert View Hospital twice in the last 2 months. I know your CEO very well, and I have been working with the Desert View Hospital. So I get what's going on out there, but I also know it's only about an hour drive to Las Vegas. If you're writing for controlled substances chronically, and you have to worry about following up with that patient, that may be a good reason to refer to a pain specialist out in the Las Vegas area.
Our patients, do you realize how poor this county is?
I'm sorry, I lost the audio there.
We don't even have transportation to get to Las Vegas.
So do you have I'm open to anything. Do you have a recommendation then on how many days you should go without re-reviewing?
I suggested to this organization 3 years ago that they hire a primary care doctor who can follow these guidelines, that just want to do, and not do the injections that anesthesiologists do, and have it so these people can have access to care, and nothing happened.
So I obviously can't speak about each individual county or facility, the problems that you have. I will tell you that I get the list of licensees every quarter, and I don't see the appropriate specialists coming in, whether they're pediatricians, psychiatrists, or pain physicians. I get it, but if this bill was written to protect you and written to protect that patient, do you want to? Yeah.
I've got to go see patients right now. So
I understood.
I think part of the question was that when you see someone else's patient that you're covering for, how much of these steps do you have to go through? Because that for you is an initial patient.
No, it's not. And again, this is defined in statute. So I'd urge you to read the statute. It's very clear. You're covering for someone. Everything should be in the chart. Again, that's why this bill is rational. When that patient is worked up the first time and you have these documents scanned in, the DW forms as we're calling them, you can refer right to them. The only thing you would have to do every 90 days is check the PDMP. You don't want to be that guy where another doctor in an ER in Vegas at University Medical Center gave the patient 30 days of meds, and you're writing for another 30 or 90. So no, you don't have to do anything. Again, if you read that bill, and trust me, I don't want to sit there and read legislation while I'm going to bed at night. But if you look through that bill, I assure you, that is not it. You do not have to work that patient up a second time. Absolutely not.
Okay, that's good. Thanks.
Medicaid patients, we're limited on trying to get a definitive diagnosis. I get an MRI and send them to PT. I have a hard time getting them referred for more definitive diagnosis. So what I ask you to do is when you have, and I ask everybody out there, If you have specific issues with Medicaid, I want to know them. I want to know exactly what happened. You referred and it wasn't covered. You referred for medication-assisted treatment. You referred for an MRI and it was denied. I want to know. So you send me an email, you tell me the workup, and I will be in touch with you, and we are going to fix this problem with Medicaid. What I will tell you is the majority of people who have complained to me about issues with Medicaid, and I will tell you, I was not a Medicaid fan being a private practice physician. I will tell you that some of the Medicaid people you have are the most dedicated public servants you will see. They respond to me very quickly, and I will tell you it's a misconception in many of the issues that I've seen from physicians. Tell me the problem, and I will look into it personally for you. Some cases of violence, even murder, physician by patient's husband who are not providing opiate medication. I know. I've seen this. I've been a part of this. Though this is likely a rare occurrence, it still has impact on the psyche of medical providers, especially if I agree. How will the public be educated on this bill? Once again, this bill was educated keeping issues like this in mind. That's why when if you decide to drug screen that patient, they come up positive for amphetamine, cocaine, they're getting them from multiple providers. Now you can say, I'm sorry, I can't by law provide you with that prescription. You've exceeded your 365 days. Again, I want you to look at that question, understand this is the rational way we viewed this bill as we wrote it, to protect every prescriber out there. This is what we don't want. Other questions, anything, please, if you have issues, feel free to email me. Any specifics with Medicaid, I want to know about them. I meet Medicaid regularly, and I work very, very closely with them. I want to know the details, and we'll figure this out. But I will tell you that 90% of the time, the complaints about Medicaid are wrong. They actually do something, and it's the physician that was actually in error when dealing with Medicaid. And I just wanted them to know, I look into every complaint personally. And pain management clinics do not accept Medicaid patients or have caps on the number they will see. You are absolutely right. I will tell you that I was one of those physicians that when the Affordable Care Act went into place, I limited my Medicaid patients. You're right. What do we do about it? I will tell you that I have a very big idea, which I've received the approval of some of our elected officials to move forward with. Which I can't reveal right now, that I'm hoping to make a large culture change in the provider community by the next legislative session. So I'll tell you, I'm working on that. And once again, many pain management clinics do not accept Medicaid. That's right, and it comes down to you as the primary care provider. Again, this Assembly Bill 474 is there to protect you, and I understood that going in.
Ely, do you have a question?
Yes, can you hear us? Can you hear us?
Yes, I can.
Okay. This is a William B. Rowley Hospital. We're about 4 hours away from Vegas, 6 away from Reno, Carson City. So we have a real critical access problem out here. Many of our patients go out of town to surgeons, neurosurgeons, and then the neurosurgeons do not want to accept them back after there's a failed laminectomy. So this has been a real problem for us. Dr. DiMuro, I'm Nancy Baker. I'm sorry, I didn't introduce myself.
Nice to meet you. Thank you for your email.
Yeah. Thank you. So I don't know if there is any type of education that we can be doing to surgeons, especially neurosurgeons, to address these issues, retake back their patients if there's a failed laminectomy.
So great question. It's something that I dealt with every day when I was practicing. Remember, the surgeons, we all know every surgeon's the best, just ask them. There's never a failed surgery, right? So what the surgeon is going to say is that the surgery went fine, it's a pain issue, and now you have to deal with it because there's nothing else I need to cut. So you are now going to be tasked with managing the pain. I get it. Again, that's why I wrote this bill this way. We wrote this bill collaboratively. yeah, it really is horrible now that you have to manage this. You're the one who has to consider spinal cord stimulation. Does this patient need injections? Should they travel 8 hours just to get a simple cortisone shot? So what I was alluding to before is this project that I'm embarking on is the main crux of this is trying to get the appropriate specialists out to the rurals and make access much better. But I don't have a solution for you in the rurals right now. I think I do have the solution, and hopefully we'll have it by next legislative session. But for the next 20 months or so, I think we're just going to have to grind it out. And I think that AB474 at least provides you a layer of protection for over-prescribing and prescribing more than you would want. But I don't think a state is going to go in, I can't tell Dr. So-and-so, you cut this patient, so you're responsible for all their pain care. They're going to say, well, they're going to have to get on my schedule and my next opening's in 3 months. Whereas you know what's going to happen is they're going to see the PA or the nurse practitioner, and they're just going to say, well, it's not surgical, and then they'll image them to death. We all know that. So Nancy, I totally get where you're coming from. This bill was written to try to help you. And again, I'm working on a project to really help the rurals that I hope to have ready for legislative session in 2019.
Thank you, John.
You're welcome. But thank you, everyone, and I really appreciate everyone tuning in. And please email me with questions, concerns. If they are specific cases, especially dealing with Medicaid, give me the details so I can go in and discuss the case specifically with Medicaid. You have my word that I will do that for you and forward everything to the appropriate people and be involved in the case. Please know that I am thinking about the rules every day, and that this bill was written collaboratively. We engaged all the physicians. We had zero opposition, and that I'm committed. This is obviously right in my swim lane as a physician, and I'm committed to doing everything I can to protect the physicians and the patients alike.
And you did a very good job. Thanks.
Thank you.
Have a great day, everyone.
Well done, sir.